Good morning, and thank you for joining the RLS Foundation's webinar titled Safe Treatment of RLS with Opioids. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Winkleman will answer as many questions as time allows at the conclusion of his presentation. The surge in the use of web-based programs during COVID-19 health crisis has created a strain on the system. If you are experiencing technical difficulty, switch to the audio portion of the webinar. It uses less bandwidth, so that's the telephone number listed in your invite. We thank you for attending and appreciate your patience and understanding during today's webinar presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal section of our website. If you are not a Foundation member and if you would like to review this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. John Winkleman. Dr. Winkleman is Chief of the Sleep Disorders Clinical Research Program, Department of Psychiatry at Mass Gen Hospital, a certified RLS quality care center based in Boston, Massachusetts. Dr. Winkleman received his PhD from Harvard University in psychobiology and his MD from Harvard Medical School. He finished a residency in psychiatry and fellowship in neurology at Mass Gen. He has served as chairman of several national organizations, including the Nosology Committee, the Movement Disorder Section of the American Academy of Sleep Medicine, and the American Academy of Neurology Guideline Committee for the Treatment of RLS. Since 2000, he has served on the RLS Foundation Scientific and Medical Advisory Board. Dr. Winkleman's research interests include sleep-related movement disorders, insomnia, and parasomnias. He is a leading expert in the field of RLS and has published several textbooks and authored over 100 articles in the field of sleep medicine. Dr. Winkleman, we thank you for sharing your time and expertise with us, and I now invite you to begin your presentation.
Thank you, Carla. I hope that everyone can hear me okay, and I appreciate everybody signing up to listen to this presentation. I understand from Carla and her crew that there are around 700 people listening today, so clearly this is a topic of much interest. My hope today is to get through my slides in about 30 minutes so that we can spend almost half the time together with me being able to address questions that you have sent to the RLS Foundation ahead of time. You should be able to see my slides. I don't think you can see me on video, which is probably a good thing because I have basically the hair that I had, and I guess I'm lucky, the hair that I had in 1983 at this point, without a haircut in a few months, maybe somewhat grayer, and I'm not sure it's a pretty sight. So now I'm having trouble. There we go. So first we're going to talk a little bit about the opioid crisis in the United States. Information that you're all familiar with. Roughly 3 to 4% of the adult population, that's about 10 million adults, are taking long-term opioids. This is in the US, long-term defined as more than 3 weeks. There are about 15,000 pharmaceutical opioid overdoses in the US per year. And these numbers seem to be going up or maybe plateauing. But there's a lot of concern about prescription opioid use in the United States, which is why this topic is so controversial. And I guess this tornado represents some of that storm. Here's a nice paper from the journal Pain, where they talk about the various ways that opioids can be used other than as prescribed. And these are definitions. And these are the things that doctors are worried about. Misuse, when people are not using the medications as prescribed, maybe using them at different times of day, maybe using them in excess at times, and then running out at the end of the month. Then there's abuse, where people are purposefully using these medications for sedation or euphoria. And finally, there's what is called addiction, where the use of these medications associated with demonstrated or at least marked potential for harm. Now, I do want to emphasize that there has to be demonstrated or marked potential for harm. Just using an opioid on a daily basis, which is beneficial for a medical problem, where there is no demonstrated harm or at least marked potential for harm, is not addiction. And this is where a lot of doctors get confused. A lot of medications are beneficial for medical treatments. That doesn't mean that you are addicted to them, like insulin, like Prozac, like your high blood pressure medicines. You are using them effectively to treat an underlying problem. For the opioids, of course, there's special considerations, but if there's no demonstrated or marked potential for harm, then we can't consider it addiction. Their misuse of these medicines is common, roughly a quarter of all people, and addiction is pretty common as well. Roughly 10% of adults using them are addicted using this definition. Doctors are worried. Here's some headlines from various publications. These are, newspapers online. And doctors are worried because they are getting sued, they're getting arrested, but they're only getting sued and arrested when they use these medications inappropriately. Appropriate prescription of these medicines follows all standards of practice in medicine. As a result of these concerns, doctors in the United States have stopped, many doctors have stopped prescribing these medicines. I don't even know if you can see my, maybe Carla, you can break in for a second, or somebody could, to let me know if you could see my pointer here on the screen. You could break in and say
Yes.
yes or no. Great, thank you.
Yes.
So that you can see here, this is 8 years ago, and here's a 6-year study showing total opioid prescriptions going down, 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 down. 30% of providers in the United States no longer write prescriptions for opioids. A third of doctors just say, I don't write those prescriptions for anybody. And again, this is why this treatment is so difficult to obtain even under appropriate conditions. So here the New York Times says, good news, opioid prescribing fell. The bad is that many people are suffering. And balancing the risks and benefits, that's what doctors do with all of their prescriptions. And as you can see, 30% of doctors don't feel that they can balance the risks and benefits with these medicines any other way than just to say, I'm not going to give anybody these pills. So I've mostly been talking about pain and opioid prescription for pain. I'm going to transition now to restless leg syndrome. In many respects, RLS has many features that are similar to pain, but RLS, the majority of people with RLS don't describe themselves or their symptoms as painful. But I'm not going to be able to go into detail here today, but if we examine this, RLS symptoms do have many of the features of a pain syndrome, even though RLS symptoms for most people are not painful. So here we are. This is a picture that I took a year ago. It was March on the island of Maui, and I happened to be there on a spectacular day and walked a couple miles on this dirt road to look at the pipeline there, where surfers were surfing these 40-foot waves, and I had a telephoto lens. And here you see this guy coming off this 40-foot wave, and I think that this is how many doctors and patients feel, who have patients who have severe RLS and are not sure which way to turn and feel that this is dangerous for them to be using opioids. It feels dangerous as a doctor to be prescribing these opioids, but that at the same time, from a doctor's perspective, providing relief to people who are suffering so much is thrilling, as this person here is thrilled, but it's associated with risks as well. So let's look back at the history of RLS, of opioid prescribing for RLS. Laudanum, opium, has been used for a few hundred years for the treatment of what appeared in the historical literature as restless leg syndrome. But the modern literature starts here with this randomized, double-blind, placebo-controlled trial of oxycodone versus placebo, and showing that oxycodone was an efficacious treatment for restless leg syndrome. And this is almost 30 years ago. The first author is Art Walters. 20 years later, a substantially larger study was done using oxycodone controlled release that we might call OxyContin for the treatment of restless leg syndrome. And here you can see that placebo did have some benefit, as it always does, but that the benefit for the controlled release oxycodone was substantially better. It was also associated with more side effects, more fatigue, more constipation, more nausea, more headache. So opioids have obviously both benefits as well as these immediate side effects. The biggest question is not, do opioids work for a few weeks or a couple of months? The biggest question and the biggest concern is, do these medicines continue to be effective over the very long term? Because as we know, restless leg syndrome is not just a problem that exists for a few months or a few years. For most people who have moderate to severe symptoms, this is going to be a lifelong problem. And so when we begin medications, we need to think about the question of whether people are going to be able to continue using the medication that we're prescribing now long term. Can they use it safely, and can they use it effectively? And this is where the data that we have, unfortunately, is relatively lacking. A paper by Richard Allen and Chris Early, now a few years ago, almost 10 years ago, looked at people taking methadone. They looked at some people up to 10 years, but as you can see, there were very few people at 10 years, only 2 people. And at 5 years, they only had data on 25 people over the 5 years. They started with 71, but many of them they had not seen long enough to follow them long term. But it looked as if methadone doses remained relatively stable, i.e. no substantial increase in the majority of people over this long period of time. But as I said before, only a small number of people followed even for 5 years. As a result of that, given my concerns about this issue and the fact that I was treating people with opioids long term, I felt that we needed better and larger and longer data on the opioids. And we'll be getting to some of the data, at least the first year of that data, in a minute, and we'll see that the RLS Foundation, along with a number of donors to the clinical research program at Mass General, have supported this ongoing research that's called the National RLS Opioid Registry. Before I get to that, I do want to briefly talk about the various opioids that are available. I think that I'm not going to go into great details here about this, but these are the opioids that are commonly used: oxycodone, hydrocodone, tramadol, codeine, methadone, OxyContin, which is prolonged release oxycodone, and buprenorphine. These are almost all of them class 2, which means you can only get 1 month prescription at a time. No automatic refills. I basically ordered them in terms of how long they last, in terms of the relief. Now, this is pain relief. We don't really know how long they last for RLS because no one's investigated that carefully, but shorter acting agents here at the bottom and longer acting agents are at the top, longer acting agents here at the bottom. So let's talk about the registry. So here's a kind of a splashy advertisement for the RLS opioid registry, which we got funding for a little over 2 years ago from the Restless Leg Syndrome Foundation and these other donors to the sleep research program at Mass General. And I want to thank both the RLS Foundation as well as these donors for their support. We were very surprised that we got so much interest in this registry. We initially felt that we would be able to enroll 200 people over about 1.5 years, and we had to close enrollment after 1.5 years at 500 people. Each one of those people had a conversation with my research coordinator at the time, Julia Perks, to ask a variety of questions, a 30 to 45 minute interview, and then go online to visited this website and answered more questionnaires. And you're about to see this data from the registry. Anybody who was taking an opioid for RLS and had had a previous response to a dopamine drug, so pramipexole, ropinirole, or rotigotine, or levodopa, were allowed to be included in the registry. You're going to see data on 500 participants, and then we're going to see some data on, we've just analyzed 369. We have about 425 participants now who we have followed now for 1 year. We've had this remarkable interest, getting 500 people very quickly, and 95% of the people who we spoke with and enrolled at the beginning continue to be involved in the registry. And the most thanks for this data goes to them. And so who's in the registry? As you can see, the average age is 65, the youngest person's 24, the oldest is 89 or was 89 at enrollment. And you can see here's the age distribution. So it's usually between 50 and 80 years old are the vast majority of people. Many of them had symptoms before the age of 20, and 38% of people said they first had symptoms as a child or a teenager. That's this 38 here. We have participants in 43 different states. The darker the color is, the more people. So you can see the most from California and a lot from the Northeast, Florida, Michigan, and Texas. And people are taking a variety of medicines. They're taking dopamine agonists, they're taking opioids, and they're taking pregabalin, gabapentin, or gabapentin anacarbal. 90% of the people in the registry had experienced augmentation of their RLS symptoms from one of the dopaminergic drugs. So the registry is limited to that population because we required that people had to have a response to a dopamine drug to be in the registry. And most people who are going on opioids who have had dopaminergic drugs in the past have been augmented. Roughly 50% of people are just taking an opioid, although you can see almost a quarter of people are taking an opioid and either gabapentin, pregabalin, or gabapentin and a carbol. About 1 in 6 people are taking an opioid and a dopamine drug, and about 1 in 12 people are taking all 3 of these medications for their RLS. When we look at the particular opioid that they're taking, almost 50% are taking methadone. Another 20% are taking oxycodone, and 7% taking prolonged release oxycodone. So a quarter of people are taking some oxycodone prescription and 15% hydrocodone. In terms of side effects, more than half of people report constipation. A quarter of people report drowsiness or fatigue. 1 in 5 with itching. So these are the most common side effects. We asked everybody in the registry lots and lots of questions, and some of the questions that we asked were about risk for opioid abuse. And there's a brief questionnaire that addresses this question. I'm not going to get into the details, but here are the questions that we ask about that, and here are the points that you get. And if you have above a certain levels, a certain number of points, then you're considered, rather than low risk, moderate or high risk. And you can see that 75% of the population of the registry is considered low risk, roughly 20% moderate risk, and a small percent are high risk. So here's the bottom line on the 1-year follow-up. As I said, we now have 425 people who we've followed for a year. Roughly a quarter of people had increased their opioid dose from baseline to 1 year. Seems like a lot of people, but over a third of those, almost a half of those, had increased it just by a little bit. A very, very small number of people, 1 out of 100 people, 1%, had increased it by 50 morphine equivalents. So these are big jumps. So only a small number of people are have increased their dose by quite a bit. And in terms of the RLS severity, as evaluated by the International Restless Leg Syndrome Severity Scale, there was no change from baseline to 1 year. So symptoms were equally well controlled at each of those times. Here you get a distribution of opioid dose changes. These are again in morphine milligram equivalents. And you can see that the vast majority of people had no change, that there were some people who had small change in these groups, and then a much smaller group of people who changed their dose substantially. You can also see that there were people who had reduced their dose at 1 year. Our plan is to continue following people in the registry for as long as possible, at least 5 years, if not longer. And this depends on continued funding from the foundation and any other sources, as well as the willingness of participants in the registry to continue answering emails that we send out every 6 months with a variety of questions addressing what they're taking for their RLS, what their symptoms are like, what side effects are like, et cetera, et cetera. And those questionnaires take somewhere between 20 and 30 minutes to fill out, and I'm hoping that the participants will continue to fill them out every 6 months, taking the 20 or 30 minutes, because this is the only way we're going to find out how well these medicines perform over the long term. I'm not going to go into the details. This breaks down the changes in opioid dose over 1 year, and I want to thank my current research coordinator, Ben Whipper, who's doing an extraordinary job analyzing this data on 500 people and probably 500 questions per person, and has luckily loves to do data analysis and is very good at it, and so has been leading that. You can see that the people who are most at risk of changing their opioid dose are people who had been on an opioid for less than 1 year at the time they started in the registry. So almost 50% of them did increase their dose, even though, again, it was by a very small amount. Another group that seems particularly prone to have to need a dosage increase are people who are using an opioid not just for an RLS, but for pain in addition to RLS. Again, almost 50%. And these people are using, their increases were substantially larger than the average increase in our population. So these are people where doctors and the person themselves may be more concerned about using an opioid for RLS if they are addressing other pain in addition to their RLS. And these are the kinds of answers that we're trying to get from this registry long term. Do these medicines continue to work? Do you need to increase the dose? Who's increasing their dose? Are you having more side effects? Are there changes in other medications over time? Are there other health changes that happen over time? So these are questions that the registry will continue to address moving forward in time, hopefully 10 or more years. So in the last few minutes, I want to address some essential questions here about opioid prescribing for RLS. This slide is mostly about what we in the field need to do to increase access to opioids for people with severe restless leg syndrome. We need to educate prescribers. Remember, most doctors, as I showed before, a substantial percentage of doctors are running away from opioid prescription. They don't feel comfortable with this. They're scared of it. They feel that their license is at risk, or even worse, they could be arrested. And we in the RLS field need to educate prescribers that prescribing opioids for RLS can be done safely and effectively. Of course, we need data to convince people of that, and this is where the registry comes in. We need to educate doctors that using a medication like an opioid every day for RLS does not mean that you're addicted to the medication. You may be dependent on the medication, i.e., if you stop it abruptly, there will be certainly an increase in RLS symptoms. There may even be some opioid withdrawal symptoms, that there is psychological dependence. When something's working, one becomes very dependent on it, but that doesn't mean addiction. Addiction is a high risk, as we saw before, of danger or harm from the medication. And we need to teach doctors that rather than running away from their responsibility, that they should address their responsibility head on. This is the responsibility that all doctors have, to always balance risks and benefits. In some people, you're going to feel that these medications are appropriate, that the benefits outweigh the risks. In other people, you may feel it's not appropriate because the risks outweigh the benefits. But running away from it and saying, I don't prescribe these medicines at all is, I don't think, acting in accordance with one's medical license. So who should be taking opioids for RLS? Opioids are for people whose RLS no longer responds to or can't tolerate other treatments. In particular, this is going to be people who have developed augmentation to dopamine agonists. The dose keeps going up, 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 up. They get temporary relief each time it works, but then over time it loses its efficacy and in fact makes the RLS worse. And what I say here is that for many people, when you start with a dopamine agonist or increase the dose of the dopamine agonist, it's like lighting a fuse. At some point, it's going to reach the explosive and it's going to explode and your symptoms are going to get worse. Opioids are also appropriate where people have not responded to or had substantial side effects with one of the calcium channel ligands, gabapentin, gabapentin anacarbol or pregabalin, Neurontin, Horizont or Lyrica. And these medicines also are very effective for RLS, do not produce augmentation. I want to be very clear, they do not produce augmentation. However, they can have side effects that interfere with their use, and not everybody responds to them. And we can use, or we should consider opioids in people who have high iron levels in the periphery, in the serum, or have used oral or IV iron and haven't responded. So these are the three main options other than opioids: dopamine agonists, these calcium channel drugs, or iron. And then the fourth is opioids. And I always hold up 4 fingers to people when I'm describing use of medications for RLS. We got 4 good options. We only use the opioids when you've exhausted the other 3. You also need to make sure, of course, that there's no other reason why their RLS is bad or not responding to other treatments. They're taking an antidepressant. They have substantial sleep apnea that's not treated, and we need to try to address those things that are making the RLS worse, in addition to try to make the RLS better with the medication. Opioids need to be a good fit for both the doctor and the patient. If the doctor's not comfortable prescribing, then they're not going to prescribe it. And education hopefully will change that, but for many doctors, it's not a good fit for them. It also needs to be a good fit for the patient as well. So, like any medical interaction, it's always a collaboration between the doctor and the patient. There's certain groups of people where I am I'm always cautious about prescribing opioids, but I'm particularly cautious in people who have a history that is of concern for misuse or abuse. So the opioid risk tool, I will use that, or I'll ask those questions to get a sense of that. Anybody who has significant lung problems where the effects of the opioid on the respiratory system are of concern. People taking benzodiazepines, these are drugs in the Valium family for sleep, anxiety, or RLS, I'm going to be particularly careful. Or people who start off with severe constipation, and therefore I have a particular concern that the opioid is going to lead to even worsened constipation, which can be a significant medical problem. How do we choose what opioid to use? I match the symptom duration over the course of a day to the drug. If people are having symptoms just a few hours a day, I may consider a shorter acting agent. But for most of the people that I see where opioids are appropriate, they're having symptoms more than 12 hours a day. And I do not allow people to dose short acting drugs multiple times a day. I think that's a bad idea because the opioid goes up, and then when it wears off, RLS symptoms are going to come roaring back, and then they're going to feel them and then need to take something, and then they're popping the medicines all day in response to these short-term fluctuations in doses. So for people who have symptoms 10, 12 or more hours a day, I'm going to be using long-acting opioids like methadone. There are requirements as part of the agreement between doctors and patients using opioids. In Massachusetts, I have to meet with patients face-to-face for whom I'm giving an opioid every 3 to 4 months. In other states, it can be every 6 months, but in Massachusetts, it's every 3 to 4 months, and I require this to continue prescribing the medicine. And if people miss a visit, I say, you better get in here because I'm not going to be allowed to write you the next prescription. The opioid agreement must be signed between myself, between the prescribing doctor and the patient. And you should expect your doctor every time they write a prescription for an opioid to check your state's prescription databases to make sure that you are not getting other medications which could increase the side effects of the opioid medicine. Not sure you're not getting those from any other doctor. So there are a couple of nice papers on the use of opioids in restless leg syndrome. You can get them from online. The one on the left, I think, is particularly good. It is from the Restless Leg Syndrome Foundation, and a number of us were involved in writing those guidelines. It's in the Mayo Clinic Proceedings. We also did one around the same time from another doctor in my group and myself on addressing some of the same issues. So for those of you who want something in print that you might be able to bring to your doctor to educate them, this is where I would go, particularly the one from the Mayo Clinic Proceedings on the left. I'm going to keep this slide up here to remind us just what a difficult endeavor it is for both doctors and patients, but particularly for those of you who are sufferers with restless leg syndrome. Your issues with this are much more difficult than the doctor's issues. And I hope that you can find somebody who can assist you in relieving your symptoms. I'm going to stop there and let Carla ask some questions.
Thank you, Dr. Wickelman. I'm just going to take a moment to let everyone know who's been calling in or having trouble getting access to the webinar for whatever reason. We will be sending out the link in an email to you, so watch for that. We'll also post it for everyone to access on our website because we know that almost 800 of you signed up to listen in on this and may be having some issues, but just know that our staff is answering your questions as fast as we can to help you get in. So thank you for that. Okay, first question. After using opioids for a while, do you see a need to increase dosages ever?
Okay, I think that this is one of the issues that I had just addressed. Mm-hmm. It looks as if the majority of people, from Richard Allen and Chris Early's study, it was a small study, the majority of people did not increase their dose. We've just got 1 year data, although we did do retrospective. We asked them We asked people, have you increased it over time? The majority of people in the registry had been on an opioid for 3 to 5 years by the time they entered. So we did have some of this information. And it looks as if there are some predictors of who's going to increase their opioid. People who, in the first year, it looks as if that's the time where opioid doses may happen. After that, it appears as if it's much less common. The majority of people will not increase their opioid dose, but people who have other chronic pain issues, that seems to predict increases in opioid dose. Next question.
Okay, some of these will be reteaches because we had a lot of people add on throughout the webinar, so this is just really a popular webinar, Dr. Winkleman. So are opioids effective in the treatment of augmentation, and why?
Okay, this is a good question. Are opioids effective in the treatment of augmentation? Opioids are effective in the treatment of RLS. The only way to reverse augmentation and to not have that process continue is to reduce, or even better, discontinue your dopamine drug. I want to make this very clear. Opioids don't change the augmenting process, I don't think. If you're still on the dopamine drug, I understand you're on the opioid as well, but if you're still on the dopamine drug, I think, and this is something that we're trying to see with the registry, but I think that your RLS will continue to worsen. So what you need to do is try to reduce or get off the dopamine drug. This is what I spend a ton of time with my patients doing, and it takes a long time. You add the new medicine, whether it be gabapentin and acarbal, pregabalin, or an opioid, and then afterwards, very gradually reduce the dopamine drug. And when I say very gradually, for most people, it takes anywhere from 3 months to a year to get off the dopamine drug. But in the majority of people that I treat, they are able to get off it. But whenever you're on the dopamine drug, augmentation will probably be continuing. Next.
As opioid prescribing in general becomes more difficult for physicians, are there added requirements for the documentation of RLS?
Yes. There's a lot of documentation, but you don't really need to worry about that. That's our responsibility, but we have to document that you've actually got the RLS, what medications you've tried, whether they've worked, stopped working, and whether there's augmentation, what side effects there were. And you then need to come to the conclusion in your note that opioids are the best option given previous failure or side effects with previous options, and that you are not at excessive risk in using an opioid of side effects that are worse than the continued augmentation that you might be having, or other risks like pulmonary problems or abuse or overdose, etc. So lots of documentation, but that's not something that sufferers need to worry about. That's our responsibility.
Can one augment on tramadol?
There's one paper that suggests that you can augment with tramadol. It's not clear how valid that is, because it was just a very small number of patients. I think it's possible, and this is something certainly that we should be keeping an eye out for. My concern with all short-acting opioids is that when they, let's say you take it at 10 o'clock at night and it works for most of the night, let's say, my concern is that when it wears off, which is going to be in the morning sometime and the early afternoon, that there's going to be a rebound of RLS symptoms, that RLS will come and grab you in the morning or in the afternoon. And whether that's genuinely augmentation or whether it's really rebound of symptoms isn't clear. But in general, I avoid short-acting opioids for this reason.
Can you please give us guidelines for managing opioids with an active case of COVID-19 with and without respiratory symptoms?
I'm sorry, could you repeat I lost you for part of that,
Oh,
Carla.
okay, happy to do it. It says, can you please give guidelines for the managing opioids with an active case of COVID-19 with and without respiratory symptoms?
I see. Okay, COVID-19.
Mm-hmm.
Certainly, opioids should be very carefully managed in someone with respiratory symptoms because opioids, in a dose-related fashion, i.e. the higher the dose, the more it's going to be an issue, suppress the drive to breathe. And if you have respiratory problems, you need to breathe faster to get adequate oxygen. So I would be very concerned about opioids in the context of respiratory COVID. In the absence of respiratory symptoms, I would be concerned that you might develop respiratory symptoms. So I would be watching very carefully. My biggest concern, though, is respiratory issues with COVID and using opioids. So I would think that your doctor would want to keep a very close eye on you if you did develop COVID infection. Next.
Okay. Do you have any observations or comments on the role of intestinal opioid receptors in the context of RLS symptom control?
Yeah, the biggest side effect that I hear from people on an opioid is constipation. And opioid receptors in the gut are going to slow down the peristalsis, the movement of intestinal contents through the gut. And so one way that this has been managed is to use medications that don't go into the brain and therefore won't interfere with opioid actions in the brain, but interfere with opioid actions everywhere else, and most importantly, in the gut. And there is a marketed medication that you may have seen on television for opioid-induced constipation. It is a peripheral, meaning non-brain opioid blocker. So it will block the effects of the opioid on the gut, allowing the gut to function more normally, but not interfere with the opioid effects in the brain. And this, I've had benefit of this medication for constipation in some people. However, the majority of people with constipation on an opioid can be managed with bowel stimulants and stool softeners. So whether it be Colace or Miralax or Metamucil or various teas that you can drink, most people can manage their constipation that way. Next.
Okay. Even though my sleep time has increased with opioid treatment, I have more trouble falling asleep. Is that normal?
I would say it's not the rule, but I definitely have seen people where the opioid has in fact interfered with people's ability to fall asleep. It's caused some insomnia. And many opioids, in fact, are not that sedating at the low doses that we use. In fact, some people do find them activating and therefore could produce insomnia. It's also possible that you have, in addition to RLS, that you have insomnia. And that now that the RLS is treated, we're just unmasking or allowing the underlying insomnia to be obvious to us. And so what I do in those cases is try to figure out if there's some other cause other than the opioid for the insomnia. And if that's present, then we try to address that, just like I would with any person with insomnia. If it's due to the opioid, then we can either try switching the opioid or giving it at another time, or treating the insomnia independently.
Have you used intrathecal opioids?
I have not. I know that there are some doctors that have. There's a few cases that have been published, but I have not personally used it, maybe because I've had pretty good luck with other approaches without needing to use intrathecal opioids.
How can I successfully approach my own physician to prescribe opiates for RLS when most providers are reluctant to do so?
Yeah, and you know, I've talked about this in the talk there. Some doctors are just going to say, nope, I don't prescribe those medicines. And you know, what can you do to budge them? That's just their stand on this. They feel that the risks outweigh all benefits, and so they're not going to do it. And you may find other doctors that are willing to be educated about the relative risks and benefits. And what I would, if you feel that they're on the fence, I would probably print out the Mayo Clinic Proceedings paper that Mike Silber is the first author of, that I showed there on the screen. Print that out, take it to them at one of the visits, and ask them, look, would you read this over and reconsider it, and discuss the fact that these are very, very low doses of opioids that are being used. But many doctors are not going to be willing, and you may have to search around in your area for someone with an open mind about this, or maybe a pain specialist who's more comfortable using opioids for medical purposes.
And I'd like to also thank Dr. Winkleman here, as this is a lot of the work that he did on the Hill last year, you know, educating our legislators about RLS and the appropriate use of opioids. So I don't know if you want to say a few words, John, or because that ties
Um,
into this issue as well, you know, and that Mayo
yes,
Clinic Proceedings paper is all over the Hill.
yes. Well, the RLS Foundation has done an extraordinary job in trying to raise awareness among legislators about what's happening in the community. Remember, 2% of adults have clinically significant RLS. This is a lot of people. And a lot of people are on dopamine agonists at doses that are too high and are producing augmentation. As I said, it's a ticking time bomb, or it's a fuse that's lit, and it's just going to explode on them. And we need to have legislators discuss with doctors that it is reasonable to consider opioids for people with RLS where other treatments are not effective and not tolerated. But it's we need to have doctors be less scared by the regulators and legislators, because that's what's driving them not to prescribe.
All right, we'll move on. Next question. I've tried 4 different opioids. They help my RLS but cause severe depression to high anxiety. Is this common?
Common, no, but I have definitely seen people who have developed depression on opioids, as well as depression on either pregabalin or gabapentin and acarbol. There are many medicines that can cause depression. The one thing that I would caution you about is to make sure that it was in fact the opioid that caused the depression and not the reduction in the dopamine drug. Because what's called DAWS, or dopamine agonist withdrawal syndrome, depression is a significant part of that. So for some people, I give them the opioid, they haven't developed depression, they're on a dopamine drug, then I start withdrawing the dopamine drug, and that's when they get depressed. And so you really need to distinguish, was it the opioid or was it dropping down on the dopamine drug? And if that's the case, then there may be other ways to address it, but not necessarily fair to blame the opioid. But this can happen with opioids, and it sounds like you've tried a variety of them, and that you've got a doctor willing to do that. Um, and all I can say is maybe you need to try another one, or try using a antidepressant like bupropion to try to address the dopamine, the depression, or some other medication to address the anxiety. But make sure it wasn't dropping down on the dopamine drug.
Next question, if opioids are your last line of treatment for RLS, what happens if the opioids stop being effective?
If opioids were the last line of treatment, did you say,
Yeah.
Carla?
That's how the question reads. If
Yes.
opioids are the last line of treatment, what happens if the opioids stop being an effective treatment option? I guess that's what that means.
We need to figure out what's going on. Um, in general, opioids do not lose efficacy. And so it's unusual if that's true. So my first thing to do would be to figure out something else is going on here that's making the RLS worse and making the requirement for the opioid dose to go up. And is it iron deficiency? And is it an antidepressant? And is it sleep apnea? Is it not getting enough sleep? All the things that we discuss in those papers that I put up there, because that's where we have to look for the, that's my first suspicion, because opioids losing efficacy is fairly unusual. And so I'm going to always try to figure out what's going on. All I can say is, given that it's the last, if it's genuinely our last line of treatment, then we may have to go back to previous treatments that we used before and add some gabapentin or pregabalin back on, or add a dopamine agonist back on, maybe use a little bit of THC, which can be helpful for some people, and certainly not as a monotherapy, is the only therapy that can help people get over the line. So there are other options as well.
Okay. Question is, next one is, I take Requip and Vicodin for chronic pain, but it doesn't help my RLS. Could this possibly be augmentation?
There's too many issues there. I spend an hour with all new patients to try to figure out what's going on. And I guess the simple answer is yes, it could be augmentation, but it's hard for me to give any specific guidance without asking an hour's worth of questions to try to figure it out. I see this, all of these medical problems, as a crime. And our job as doctors is a whodunit, is to ask, to bring in all the usual suspects and interrogate them, ask lots and lots and lots of questions to try to figure out who done it. And that's why it takes so long to figure it out, because it's complicated. And so unfortunately, I can't give you good guidance without the answers to a lot of questions.
And if you can get to a quality care center, we've got 9 US based, that would be a good option for you once we get through, it's safe to travel and we're through this COVID crisis. Once you start an opioid for severe RLS treatment, what are the chances you will ever be able to discontinue its use?
Severe RLS, let's say moderate to severe RLS, in the vast majority of people is a chronic medical condition. So whatever you're going to be using for the RLS, unfortunately, we probably need to consider it or something else as going to need to be used long term. Now, if there are underlying things causing this, iron deficiency, use of a serotonin antidepressant, severe untreated obstructive sleep apnea, etc., then maybe you could get rid of your RLS by treating those things. But in the absence of those, we probably need to consider your RLS, if it's moderate or severe, to be a lifelong condition. And therefore, we need to think about the treatments as something you should unfortunately, accept may be lifelong treatments. And this is true for a lot of medical problems. In medicine, we don't cure many things at all. We manage chronic illness. And that's true for RLS as well.
All right, so our last question to you will be, what RLS research are you working on?
I love that question. Thank
Me
you very
too.
much. Maybe my research coordinator put that in there.
No,
Thanks,
Carla
Ben.
did.
Well, the registry is an important part of what we do, and we are lucky to have support from the foundation as well as other donors. And I want to thank them, because that takes a lot of our time and attention. I also do RLS research I was just telling Carla about this, looking at national drug utilization, trying to figure out who's using RLS, who's using RLS medications and at what doses, trying to use that to educate doctors about appropriate dosing of these medications. We found that a significant percentage of people taking pramipexole are taking it well above doses that are recommended by the FDA. I'm also doing research in people who have opioid use disorder. They are truly addicted to opioids and usually using them not from prescriptions, but for getting them on the street. And looking at the high rates of restless leg syndrome as people withdraw from opioids there. So people with opioid use disorder, as they withdraw from opioids, roughly 50% of them develop restless leg syndrome. And I think that for a significant percentage of people, that prevents them from getting off the opioids, because the only thing they can figure out to do to stop these terrible sensations, and they're very bad in people withdrawing from opioids, the only thing they can do is to go back to using the opioids. So I've applied for money from the National Institute of Drug Abuse to examine this phenomenon and determine whether whether RLS treatments like the dopamine agonist can be used short term to try to assist people in getting off of the opioids that they are addicted to. So this is very different than RLS sufferers, who I think are the majority of people listening today. These are people with an opioid addiction problem who then develop RLS as they're withdrawing.
Exciting information, but I really appreciate you taking the time to present this webinar. It was extremely popular, and so that tells you where we are in our community as far as need for education and support for these questions. And I thank everyone for joining us, and everyone have a great afternoon.
Thank you very much.
All right, thank you.